as usual, the game plan. It's mainly pattern analysis of hepatobiliary lesions. Before that, we have to know the histology of the hepatobiliary system. It's very, very important. Then we will end it up with a take-home message. References, we talked about it. At the end of the lecture, you should have a systematic approach to hepatobiliary lesions. To interpret the liver biopsy, we need relevant clinical information. Without clinical information, the liver biopsy is just finding the pathological features. There is no final diagnosis without clinical information. In the clinical information, we have to know the age and sex, symptoms and duration. The main point you have to remember here is 6 months. If it is more than abnormal liver function test more than 6 months, then it will become chronic liver disease. Then coming to the biochemical test, you should be having hepatic pattern, cholestatic pattern or mixed pattern. I'm not going into details of biochemical testing. You all please refer Todd and Sanford. It's a very nice clinical pathology book. They talk about liver function tests. All the function tests, the exam going PG should be knowing, and please read from Todd and Sanford or Henry, whatever you call, both are the same. So when you see abnormal liver function test, you have to see whether it is a hepatic picture where hepatocytes are damaged, cholestatic picture where there is obstruction of the biliary epithelium, or a mixed pattern. Then coming to the molecular. The molecular one, it's very, very important, especially in metabolic diseases like hemochromatosis. They make the diagnosis now because of the particular molecular signature. Radiology is very, very essential. Now radiology is known as part of the gross examination. You all know diagnosis is made at the bench, grossing desk 70% of the time. So radiology is part of the grossing, and without referring to radiology, you should never diagnose, especially in mass lesions. And certain obstructive diseases, for example, primary sclerosing cholangitis, the radiological diagnosis. Then coming to indications of biopsy, why they have done the indications. So that is also very, very important. We will let us see step by step. The indications, it can be, is it for diagnosis, is it for prognosis, or is it for theranosis? For example, if it is hepatitis C, they give specific treatment. So why they are doing the biopsy, we have to know that. And the last thing, but not the thing, is the medication history. Medication, I don't want to stress more than anything. Medication is very important for renal and liver disease. As you all know, all the medicines are metabolized in the liver and excreted by the kidney. So both liver and kidney disease, we have to get the medication history, because whatever changes we are going to see can be produced by any type of medicine. Starting from hepatitis, some medicine can give autoimmune hepatitis like picture. Some medicine can give hepatitis B like picture. So medication history is very, 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 very important, and you have to get it from the clinicians. So it's better to see the biopsy along with the clinicians. When the slides are ready, you first see without any history, because when you get some history, you will get biased. So do it without any clinicians. Before talking to clinicians, you have a look by yourself, form a differential diagnosis, then show the know the clinical history and ask the clinician to come. It's better if you see the biopsy along with the hepatologist, so that you can serve better the hepatic diseased patients. So with the clinician, when you see, they will give the nice history and you can correlate. And as I am telling you again and again, without clinical history, it is only interpretation of the histopathological findings. It is not a final diagnosis. Coming to biopsies. Biopsies can be done outpatient or inpatient. It can be for surgical disease or medical disease. The most of the lecture today we are going to cover only on the medical disease. So medical disease, we have to go for core biopsy. There is no point of doing FNAC in abnormal liver function test. We can't diagnose anything. FNAC is mainly for surgical disease. That you have to remember. Any liver biopsy, first you have to see is it a medical or surgical, because your approach will be totally different. Surgically, a lesion can be FNAC, a lesion can be core biopsy, or they may take a wedge biopsy, or they may do a partial resection, or they can do a hepatectomy followed by transplant. So these are all the types of liver tissues we may be seeing, mainly inpatient, outpatient. Core biopsy and FNAC can be done as an outpatient ambulatory procedure, surgical and medical liver disease. These three things I already talked about the indications. Just we will go through quickly, and you have to know what are the contraindications and complications also of the biopsy. The indications are mainly abnormal liver function test or mass lesions. In the abnormal liver function test, many times they do biopsy for primary diagnosis. For example, they don't know what is happening, unknown cause. Can it be NASH? Can it be alcoholic liver disease? Can it be hepatitis B? They don't know. So for primary diagnosis, they may be doing the biopsy, or for suspected causes. They might have done serology, the liver kidney microsome antibody may be positive. So they are suspecting autoimmune hepatitis. So they are doing the biopsy. And the last one, they may have already serological diagnosis, but the patient may not be responding to the treatment. So they may think there may be some other disease, more than one disease. For example, HCV and non-alcoholic steatohepatitis. So it may be for primary diagnosis or for additional information. Serologically, the patient, they proved it is hepatitis C, but they want to know what is the grade and stage. I want to stress, grade is activity, stage is fibrosis. The clue I remember is stage has to be very strong, then only you can dance on the stage. So it should be fibrosis. Whatever we talk in the liver, grade indicates severity of the inflammation, stage indicates fibrosis. And then additional information, they may already have the history of HCV or non-alcoholic steatohepatitis. They want to know how much the patient responded to treatment. That's why they may be doing the biopsies. These two things you have to be, is it for primary diagnosis or is it for additional information? Coming to contraindications, uncooperative patients, ascites, bleeding disorders, vascular lesions, and hydatidic cyst. Hydatidic cyst, I don't know. In the books, they are giving it is contraindication, but practically some people are aspirating the hydatidic cyst. Some of the articles are saying it can be safely biopsied, but I leave it to you. But those are all the contraindications. In case of bleeding disorders, another way, usually they do go through the skin to take the liver biopsy. But in case of bleeding disorder, they may go through the jugular vein, they may go into the liver, and they take the biopsy. Transjugular hepatic biopsies can be taken in case of bleeding disorders. In the exams, they may ask, bleeding disorder is there, but you have to take the biopsy. What is the other methods available? Please remember transjugular hepatic biopsy. Coming to complications, can be pain, always give paracetamol in their hand. Bleeding, it can be either intrahepatic peritoneal or communication with the biliary tree producing hemophilia. Sometimes in severe cholestatic jaundice, biliary peritonitis can come. It can get secondarily infected, and the bacteremia and sepsis may be there. These are all the complications.